Hi, I'm Tim Wiedrich, Section Chief for the Health Resources and Response Section of the North Dakota Department of Health. And this is our statewide long-term care tactical briefing. This is a jointly sponsored meeting with the Long-Term Care Association. And so we'll check in with Shelley Peterson to see if Shelley has any opening comments. Shelley?
Hi, Tim. Thank you. And welcome to the call, everyone. We look forward, hopefully, to a really good discussion. I know on our last call a couple of weeks ago, there were a lot of questions on the new CMS visitation guidance that came out. So hopefully today, based on the guidance sent out by the VP3 team and a lot of discussion today, that there's clarity. And again, don't hesitate to raise questions and call in that portion of the program, because we don't want you to leave with your answers not completely, your questions not completely answered. So again, have a great afternoon, great discussion, and thank you for joining us today.
Thanks, Shelley. We're going to be leading off with Faye Salzer regarding infection control. And because Faye's not going to be in a position to be with us for the entire meeting, we're going to go straight to questions and answers right after Faye's conversation with us. That is going to be happening again, following the presentation or the discussion. So I'd invite you now to go ahead and queue up so that you're available for your questions. Don't hesitate to call in at 855-361-4591. That's 855-361-4591. And be sure to hit star and then pound so that we know that you have a question or a comment to make. So Faye, it's all yours.
Hi, everyone. Vanessa wanted me to try and point out some highlights of the changes on the documents I sent out this week. And so the first one I'll go to is the screening for healthcare employees. The biggest change is that in question 3 and 4, it pertains to unvaccinated employees if they're answering this question yes. So that is the change on those. And then the changes correlate down below then with whether they're answering yes to those questions. The other one would be the healthcare worker return to work. And again, those changes were specifically for the fully vaccinated employee, that they no longer have to quarantine unless they are symptomatic, even following a high-risk exposure. I just want to really emphasize that you need to look at the definition for fully vaccinated, and this is for healthcare workers as well as residents. Fully vaccinated means that they've received all of their shots that are required for the type of vaccination they're getting. So we do have Johnson & Johnson out there, that is the 1 dose, but I believe most of the healthcare workers to this point, as well as residents, have received either the Pfizer or the Moderna, which requires 2 doses. Fully vaccinated means 14 days after they received the final dose they need in their vaccination series. So just because somebody got a second shot does not mean they are fully vaccinated at that point. And so you need to really know the vaccination dates and understand what that fully vaccinated part means for that. The face mask reuse. Most of the changes in there were due to the Patel system ending at March. So the contract has ended, and right now, and Tim will correct me later if I'm wrong, the doc is planning to do that process themselves, but they are not at this point. And so when I talked to Julie Sickles, she said you do not need to store all of those masks because they don't know how far out they are at this time. So the recommendation is switch to that you can discard versus moving or storing those masks until they can be sent to someplace. Eye protection changed also. The eye protection now is if your county levels are higher, where you would move into the yellow or green, you should consider wearing eye protection again. And then the best practice is to be wearing that eye protection with your unvaccinated residents. And I have gotten some questions asking why would a fully vaccinated healthcare worker have to wear eye protection? But we have to realize oftentimes our residents, even though the recommendation is that they should wear a mask when someone's in their room, that often doesn't happen, or the resident can't tolerate a mask. And so even though that healthcare worker is fully vaccinated, there are variants out there, and there is still the potential to become infected with the virus. The vaccine does not say you will never get COVID, even though we hope that's what's happening, but there is that potential to still become infected with COVID, which means you would be exposed if the resident wasn't wearing a mask and you didn't have eye protection on. So not saying that you'd have to quarantine, but that's the potential then of risk of a reinfection of a fully vaccinated person. And there are variants that are out there as well. So it's still a good practice to have all your healthcare workers wear eye protection with their unvaccinated residents. And then, of course, realize that you still need to wear eye protection if you have anybody in quarantine or in the COVID unit or in isolation that requires that eye protection component. And then for the long-term care, to be honest, if you pay attention to the document, if you want me to highlight all the changes, that's pretty much the whole entire document. I think we had a 3-page document, and now with all the changes that occurred with that update from CDC and CMS, it's now a 10-page document. So probably other than the first page of the document, there is changes throughout the entire document. And so I really, really hope everybody is reading that document from beginning to end and getting up to date with all the changes. And so I think it would just be easier to move to questions now, Tim.
All right. Thank you so much, Kate. Let's go ahead and make sure that you're calling in. I don't have anybody actually in queue at this point. So dial up right now if you have a question or a comment. That number, once again, is 855-361-4591. And be sure and hit star and then pound. And so I don't have any callers at this point. Let me see if Vanessa or Shelley have heard of any of the questions that may have been circulating that we haven't gotten a call about yet, and see if you have anything that you heard prior to today's conversation that you'd like to raise.
Yes, I do have one. I do have a few questions on goggles. It says here, eye protection. If a building has no COVID, can a staff person wear the same goggles between rooms?
Yes, if that person is not in any form of quarantine or isolation, yes, they can wear that eye protection between. They have to take in mind that if something would happen in that room where their eye protection might have gotten coughed on or sprayed on, even though they're not a so-called COVID positive resident, it's still a contaminated eyepiece, and they would need to disinfect it before they continue to wear it for their own safety, as well as going back and forth with other residents.
Great. I don't have any additional questions or comments yet. Vanessa, anything more? Vanessa?
I'm sorry, I'm just looking through my questions here. The question was, does eye protection need to be worn if you're in a room with residents who are fully vaccinated?
You should not have to wear it. Unless, again, they happen to be under assessment for a possible reinfection. We are seeing that happen. So again, that's just general guidance. If you do have somebody that you're suspecting or being assessed for continued shedding versus reinfection, you would need to be wearing your complete PPE that's required.
Okay, I'm going to shift now to Can Faye go over the 14-day quarantine?
Okay, the 14-day quarantine is for a new admission or hospital return that is not vaccinated. They continue to require the 14-day quarantine. Or if you have a hospital patient or a new admit coming in that has been identified as a close contact, they still have to quarantine even if they're fully vaccinated. So you don't want to just assume that nobody told you they're COVID positive or, anything like that. You have to actually assess them on your admission to find out if they've been exposed to a close contact in those 14 days prior, or visit with the hospital when they're talking to you about discharging to make sure that there's no close contact identification before they come back to you.
Great. Vanessa, I'm going to ask you to hold for a bit because we do have a caller on the line. Go ahead, caller, with your question or comment.
Just a quick question for Faye with the goggles. When you first came on, you had mentioned that if our staff are fully vaccinated and they come in contact with a high-risk exposure, they still would not have to quarantine. So why do they have to wear goggles in the rooms of the residents who are unvaccinated? Because they wouldn't have to quarantine regardless. So if you could just clarify that, please.
And I think I talked about that in my response. Even though they're fully vaccinated, just like you are and I am, whoever took the vaccine does not guarantee you from not becoming infected with COVID again. So if the resident's not wearing a mask, and whether you're fully vaccinated or not vaccinated, and they are a positive case that you didn't know about at the time, with their respiratory droplets, they can infect you via the eye by not being protected. So even that fully vaccinated staff should be taking precautions. To be honest, it's up to you. If they become infected as a reinfection, that's just a healthcare worker. You're not going to be able to have work to isolate. So the recommendation is actually helping you keep your workforce available to you.
Okay, thank you very much.
Does that make more sense?
A little bit, yeah. I guess it just seems kind of funny that if you're exposed out in public, you're not a close contact, but if you're exposed in the nursing home, then you would be exposed and considered a contact. So just kind of a little gray area there, but
you're still considered a close contact, whether it's in public or nursing home. And if you're fully vaccinated, you don't need to quarantine. You can continue to work. But that does not mean you won't become a secondary infection by being exposed. So that's why it's recommended. It's not going to affect their quarantine status of if they're going to be able to work or not, as long as they remain without symptoms and don't develop COVID, but you're increasing their risk of becoming a reinfection by not taking those precautions with unvaccinated residents.
Okay, perfect. That helps. Thank you very much.
You're welcome.
All right, that was our only caller so far. Again, I'd encourage people to go ahead and give us a call if you have a question or a comment. Number again, 855-361-4591. Vanessa, any more on your end?
Yes, I do have some. Thank you. So if the resident returning from the hospital, no matter how long they were hospitalized and are vaccinated, they would not have to be quarantined. Is that correct?
Unless they have been identified as a close contact, correct.
Okay. If the resident leaves the facility overnight with family, what are the quarantine rules?
Well, it varies depending on vaccinated versus vaccinated. So you're going to have to refer to the document as that is explained in there. The main thing is you're going to have to reassess that resident for their potential of exposure during their outing. And so that mainly applies to the unvaccinated, but you still have to make sure the vaccinated during that outing hasn't been exposed to any positive cases. So you may not know that for 3 days, 4 days, where the family calls you and says, hey, so-and-so tested positive and my dad was here during their infectious period, or, my mom was here, or something like that. So you still need to do really good education with the families when they're doing outings with them to make sure that you are notified. So education and documentation, flyers to give them to help them cue that. For the unvaccinated resident who goes out, if it's greater than 24 hours, the recommendation is that you assess them at their potential risk for where, everything. It's going to be case by case. There's really no black and white. So where did they go? Who were they with? Was source control in place? Things like that. And then you're going to want to monitor them for 14 days. If they develop symptoms, of course, you need to put them in quarantine and do testing. But yeah, it's all in that document, specifically what needs to be done. So there's really no black and white. It's going to have to be looking at that case.
Okay, Faye, you and I will just continue our conversation here. Can they, if they have a roommate, can they return? Okay, let me say it word by word. Can they return with a roommate if their roommate is not fully vaccinated?
So I think they're asking if they have to be put in a private room after their 24-hour outing.
It's possible, yes.
Is that how you're interpreting that?
Yeah, that's. I believe that's what they're trying to say.
Okay. And again, we always say if they have a roommate, to at least pull that curtain for those full 14 days and limit that contact. And that would, be more for the unvaccinated resident going out. But there is no guidance unless we know they've been exposed that we would do anything to put either one in quarantine. And then we also recommend that while you're monitoring the resident, you would also then monitor that roommate, which not positive. I guess I could pull the document up, but I believe that states that in the document as well. And then we also recommend that you consider testing those at 5 and 7 days after that extended outing as well, because we do have to remember there is that potential of asymptomatic cases.
Thank you. I have one more so far that's come in. Can you talk to the travel guidance and healthcare workers?
Talk to it. I know there's a lot of discussion. I was not, but one of my colleagues was on a national call with CDC, and they're basically saying that healthcare workers and visitors qualify for those in need of quarantine, no matter what the vaccination status, because one of the key items on there is to avoid contact with vulnerable population, and the nursing home definitely qualifies for that. So again, it doesn't identify travel. So we do look at more of that as a public transportation, whether they're flying or trains or things like that, if it's by personal vehicle. And again, it becomes an assessment of whether they did source control while they were on their vacation or if they did not. So all of those things would need to be taken into context and your assessment of that private vehicle transportation to their vacation, during their vacation.
Okay, thank you, Tim. I don't have any more that have come in unless Shelley has received some.
No, I'm good.
All right. Well, I think we've exhausted the questions then, because I have none online here either. So thank you, Faye, and thanks to all those that called in or made their questions known to us. Let's go ahead and move on to the next topic then. That's COVID vaccine, and this is an update that's going to be done by Jenny Galbraith. Jenny?
Yeah, thanks, Tim. Let me get our rates shared here so everyone can see kind of how we're doing. Thank you, just to start off with, for everyone who reports every week. These rates are really helpful. Your data is really helpful for us to see kind of what's going on in the state. So kind of along the theme we've been seeing for the last couple of weeks, our resident vaccination rates are fantastic. In fact, almost 91% of our residents have at least started the vaccination series. So that is super exciting. We always love to see that. More kind of good news, tempered good news, is that our staff vaccination rates are continuing to climb. So for this last week, about 56% of our staff have started a vaccination series. We would love to continue to see that climbing. Really, our goal is 80% or higher, but it is kind of promising to see that staff aren't continuing to say no, and that some are changing their mind and getting vaccinated. We do, of course, always have our all-stars, and I'm happy to report we did add a couple all-stars here this week. We're up to 26 separate facilities who meet 80% or higher vaccination start rates for both residents and staff. So again, kind of my plea every week, if you are on this list, please let us know what you're doing to get these rates, because obviously you're doing something right. And hopefully we would be able to use your process to share with others who are maybe struggling a little bit more to get that last bump up in staff vaccination. I also did want to mention, because I've received a couple calls on breakthrough cases. If you have staff or residents who are tested through kind of your normal testing, where they have a PCR done through the Department of Health, you do not need to reach out to the Department of Health to get that sequenced. We will take care of kind of pulling that sample and getting it all kind of taken care of. Obviously, if you have additional questions about vaccine or about breakthrough cases, continuing to call in. But if you just are calling to kind of make sure that specimen, we know about that person, we know about that specimen, I can assure you that we do know about them, and we are working on getting them sequenced. And that is all I have.
All right. Thank you so much, Jenny. Alicia's going to be leading off the conversation about testing. Go ahead, Alicia.
Thanks, Tim. Couple updates with testing. We've been getting a lot of questions in regards to whether the platform for PCR testing is required versus Binax. Again, it is totally up to the facility what platform they choose to pick for their testing event. In regards to PCR testing, if you guys are requesting PCR testing, go ahead and give the schedulers a call. It remains pretty open, so we're able to get you those dates and those times scheduled. But again, it's totally up to the facility whether you want to test with Binax or PCR. So just a reminder about that. Outbreak testing, just a reminder that outbreak requires you to test every 3 to 7 days. Some people are still getting that confused with thinking that they have to test twice a week. It's on a frequency of every 3 to 7 days, and you need to go 14 consecutive days without a positive, and that's for both residents and staff. In regards to the Binax testing, we are going to be reaching out to the facilities within the next week just to see how things are going, make sure you guys are aware of the reporting system, making sure that your access for Dynamics is working, just seeing if you guys need supplies or if you need coordination of how to order those supplies, just kind of going through, seeing how things are going. And I do have Adam from the National Guards that is helping me. So if you guys do receive an email from Adam, that is because he's working with gathering some of that data. And it's not necessarily to, if you don't wish to use Binax as a testing platform, that's okay too. We just want to reach out to everybody and let them know how to to go about that if that's something that they wish to do, or whatever the case might be, just as a resource. In regards to the dynamics, we continue to get facilities their independent access and their security set up. We've got quite a few facilities already set up. And then once you guys do have that access set up, just a reminder that you guys do have to use that QR code that's sent to you. And I've also been sending out the link via email. And that is how you are going to register all new staff and residents. You are going to use that link. If you use the generic link, which is the testreg@nd.gov, it will not go into your security bank. So if you were to ever do the independent access with Dynamics, those people would not be accessible when you enter their birth date into testreg. So that's why it's so important for you guys to use your individual link for entering new people. And then if you do get independent access and you go to enter a person in and you put in their date of birth and they don't register, it's a possibility because they haven't tested for a while, or that person wasn't put into your security classification. So you can go ahead and use that link or that QR code that's sent to you and register them, and they will appear for you. And then with the independent access, some people have experienced some password issues. And so just as a reminder, they can go ahead and call 701-328-4470, and that will assist, and that number will assist them with their password reset for Dynamics. And then the other thing is too, as we continue to set facilities up with independent dynamic access, we really appreciate all the facilities doing that linking and helping us out there. But I also want to remind everybody that that doesn't mean that you have to be independent from here on out. Some facilities have experienced some illnesses, or they've finally decided to take a vacation or whatnot. You guys can still request doc assistance. Just let Cody or Misty know, and we will go ahead and schedule that assistance for those events. We're not requiring you guys to be independent from here on out if you guys do get that independent access. And then we are also still performing fit testing events. And if your facility would like to schedule an event for fit testing, go ahead and reach out to the doc, and their number is 701-328-0707, and you can ask for Sherry Hardy and get that event scheduled. And then I also wanted to just remind facilities that with surveys coming upon many, some of the information that surveyors may be requesting is test results. You can go ahead and reach out to the lab customer service if for some reason you're not able to access those test results on your lab portal. So you do have a PDF version on your lab portal that you should be able to pull up. And if you're having problems with that, you can reach out to myself or lab customer service, or I can also pull those results for you as well. And again, my phone number is 701-319-8762, or you can email me at aeminist@nd.gov. And then the lab customer service phone number is 701-328-2368. And make sure that you do leave a message, because they don't return phone calls if they're just missed phone calls. The only other thing that I have in regards to that portal is if you did have testing done and the samples were sent to Mako, you won't find those results in your lab portal. So you will have to reach out to us if you did not receive those. And I think that's about all I have. We do have Melissa here from the lab, and I have asked her to do a demonstration on how we are going to do the online orders for any PCR testing that you guys are going to be doing outside of your scheduled events that the linking cannot be done. Melissa, are you on?
I am here.
Perfect.
Do you want me to go ahead and do the demo right now?
Yes, please.
Okay. So I am going to share my screen with you guys. Can everybody see the North Dakota Be Legendary, the login page for our portal?
Yep, we can see it.
Okay, so what you're gonna do is just by starting out, I'm just gonna log in under me. It'll be easier. But the username is gonna be your 3-digit facility code. The password should have been set up when we reached out to get the information, the contact person, all of that. So you're just gonna log into your portal. So I can see all the tests that we have done. So this is an obnoxious number compared to what you guys will see per your facility. But this is the dashboard. This is what it looks like. You can click on these individual tabs right here. The one thing that you guys are going to be utilizing is the ordering tests, the view reports, incomplete orders, in transit orders. I have found that a lot of facilities like to go in if they have patient demographics or patient information prior to a testing event, or it's a clinic, and I know some clinics have people call ahead of time, so they have the patient information. What you can do is you're going to go into order tests, and this is going to be what everybody sees. It's just for COVID. You're going to click on that. Here is where you're going to do, you can start typing a patient last name. So if this person is in the system, all you're going to have to do is enter once it pops up. If it's a new patient, you're going to hit the add button. And this is where all the patient demographics are going to come in. So you're just going to type in all their information. Their phone number. And the one nice thing is once you enter this one time, it will auto-populate. The patient will auto-populate. So you only have to add the patient one time. And if this patient is reoccurring and has several tests done, you're just gonna have to click on their name. You're not gonna have to go about all of this every time. Here, you're just going to hit submit, and that's going to save that patient demographic information. The next thing that you're going to see is this will be different for every facility, the submitter information. So obviously the facility name is going to reflect the facility that's ordering, facility code, all of that stuff. Ordering physician, clinician, again, you guys should have in here whatever physicians that you utilize. This is the only one that we have in for this. The NPI number does not show up. It is not a required field, so that can stay blank. And then this right here is where you're gonna do the collection time, date, and then what the specimen source was. One thing that a lot of facilities have utilized, like I said, with the clinics, if they have the patient information prior to the testing event or prior to that patient coming in, one really nice thing you can do is you can get all of this information imported and put into the system. And rather than hit submit, you would hit save. And when you hit save, it's going to ask you if you want to save this order. You're going to click yes, close, and then it's going to go into this incomplete orders tab. So then the day of the actual testing event or whenever that patient plans to come in, it's going to be sitting right here. And so then all you have to do is click on it. Everything is going to auto-populate, and you're going to be able to do collection date, the source of specimen, and now you're going to hit submit. That's going to prompt you to this, just letting you know that you're ordering the test. You're going to hit agree. And then this is going to prompt you to questions. This is also going to print off. These questions and answers will print off on the requisition that will be printed and put in with each specimen. So I'm just going to go through quick. You're going to hit submit again. And here's where you're going to be able to print. You just hit print here. So this is what you will print off for every individual that gets tested. And this is what's going to go in with the specimen into that bag. This is now the barcode that we are going to scan. Information that we need on the test tube itself will be the patient name, the date of birth. You can put, some facilities do put the source of specimen and collection date, but the two things that we really need are the tests, the person's name, full name, and it cannot be nicknames. So if on here, the first name is Melissa and the last name is Schmidtke, you can't have the first name as Mel and then put on the tube Melissa. We will reject that sample just because we don't know for sure that there might be a Mel Schmidtke out there as opposed to Melissa Schmidtke. So just make sure that the tubes match what you put in for the patient information. And all we need is the patient full name and the date of birth. So this is what's going to get printed. Once you guys are done entering all the information, like I said, those questions and answers pop up here. Are there any questions thus far?
Usually they wait till the end, Melissa, but
Okay.
I think the thing to reiterate is that this is going to be replacing the handwritten order that we used to put with the lab samples. This is the new form that needs to go with the samples that are sent to the lab.
Yes, that is correct. And I know we have had a couple of facilities that have done this whole process, but then actually filled out a paper requisition and sent the paper rec and didn't actually print out the requisition that comes with this lab web portal. So in that case, if we don't have the lab web portal requisition, we are going to use whatever is in that bag with that sample. So for instance, they had gone through the process of ordering through the lab web portal, but did not print the lab requisitions that go with each specimen. And then they actually filled out paper recs and sent those with the samples. So that's actually what we used was the sample, was the paper rec, because we didn't have anything linked to the lab web portal. So that's just something to keep in mind. Yes, this is to replace the paper requisitions that you guys are filling out or were filling out. And we should be going to this. We reached out to everybody and wanted by March 15th for everybody to start utilizing this more than they were in the past. So far, facilities have been super, super great. So we appreciate your guys' willingness to learn another new process. I will go through, so I kind of went through the incomplete orders where you can enter patient demographics, all of that before the actual testing event. One nice thing is once the orders are in and you've sent the specimen to the lab, you're going to see them here. And it's going to tell you all the information. And then if we go back to the dashboard and we do all orders, I have a lot, so it might take a minute. here is where the zigzag line, if you hover over that, it's going to tell you where that specimen is at in the whole process. So once we receive it in our lab, you're going to see that, and you're going to see once it gets onto a machine and is being ran, you're going to see that. And then once a report is ready to be viewed, it's going to say published report. Once you open that report, it'll go to the viewed reports. One nice thing is when you go into the viewed reports, you can access all of if you know the A number, if you know the patient last name, you can always go up here, and always at any point in any screen here, you can just type in the patient name. If you know the specimen ID, you can type that in. If you want to search by date of birth, you can do that also. By clicking on this PDF, it's going to ask you if you want to download it. You can download it. And here is the actual report then that you can print out. Email, save, whatever you guys need to do per facility.
And then Melissa, do you have your contact information or who they should contact if they misplace their access to get into this facility portal?
Yeah, absolutely. Whatever is easier, I can send out an email to you, Alicia, or I can just verbally give it to you guys now, because I will be the one that you contact if you have issues with the lab web portal.
Can you verbally state what your contact information is, and then we will also get it to Vanessa so that we can send it out in one of the updates?
Yeah, absolutely. So my direct line is 701-328-6582. And then my email is M as in Mary, A Schmidtke, SCHMITCKE @nd.gov.
Perfect. And I know that you had started this process quite some time ago, and it was kind of during our crazy time. So some facilities may not even realize that they have access to this portal just because there was tons of emails coming in. So we are more than happy to get facilities that information again, if for some reason that access was overlooked, or there may have been somebody that's been replaced in the meantime. So if you guys do need assistance in getting a hold of Melissa, you guys have my contact information, or Misty and Cody can also get you guys that information as well. So I don't know, Vanessa, do you have any other questions for Melissa that you have coming in?
I did have some questions come through, Alicia. I sent them on to you. There is some confusion wondering if this is to be done with mass testing, and if all employees have to be added. From my understanding, it's all staff and residents that need to be added so that you can request that these orders be processed, correct?
Nope. So as far as events, they are going to continue to have events set up through Dynamics, and that will be the linking process there. And then this is only going to be for when a facility performs a PCR test outside of an event. So say a facility has a staff member who says they're ill and they want to do a PCR test on them, and it's not on a regular event day, they can do a PCR test and send that into the lab, but they're going to use the portal to do the paper form to send in with it, because they're not going to have an event created so that it can be linked to that specimen. So this process is just basically going to be replacing the handwritten paper requests that we did for those one-off tests in the past. And you don't have to go in and enter all of your residents and your staff into that. The only time that you would have to enter the information that Melissa had shown you is anytime you're requesting that sample that is going to be taken outside of a normal PCR event. It's just going to be that one-off sample that you're sending to the lab. And with this process, it's going to help speed up you guys getting your results, because when you do the handwritten form, when that gets to the lab, all of that data has to manually be entered before it can start that process. So as Melissa had indicated, they just scan that barcode when it gets there, and then they can get that process going for getting the results.
All right. Well, I think we'll go ahead and close out on this topic for now and move on to the VP3 update. We'll be coming back for questions and answers in just a bit, but let's check in with Seth and or Roseanne.
Yeah, good afternoon, Tim. Thank you. I'm going to go ahead and start our dialogue this afternoon, and then I'm going to turn it over to Roseanne after I wrap up to kind of mirror and complete our discussion. So before I begin, I just want to thank everyone. I know that the past week has really been full of a lot of questions, full of a lot of uncertainty. And I think that we've all been in the same boat trying to sift through the vast array of information that has come down from both CDC and CMS. And so we really just wanted to make sure that we took the time to accurately go through the data and the new information, make sure that we asked any questions that we needed to before we release some new information to kind of help guide you when you're moving through facilities on a daily basis. And so I know that people were anxious to get this. And again, we just appreciate everyone's patience, as we really just wanted to provide you with the most updated and accurate document that provides current clinical standards of best practice. And again, we had to kind of ask some questions ourselves in order to guide this. So I think that Vanessa had sent out the revised document with today's update. So hopefully everyone has a copy of that and is able to go ahead and follow kind of along. I'm going to just highlight some of the changes that have ensued. Everyone, I think, has the document and can read through it, but I just really want to take this time to go ahead and highlight the big changes that have occurred so everyone's well aware of those kind of moving forward here. So in the beginning is the preamble, which has always been there, that kind of talks about the long-term care guidance. And there's just a few points in there that I want to highlight. As always, all skilled nursing facilities must comply with the guidelines that are set forth in QSO 2039NH. And so a lot of the recommendations and guidelines in here for skilled nursing facilities essentially just mirror elements of that newly revised QSO memo. However, since basic care and assisted living facilities are not regulated by CMS, a modified visitation and service guidance for these facilities was established in accordance with current standards of practice as set forth by the Centers for Disease Control and Prevention. And so again, that was really the driving force behind this document and a lot of the elements within it. So on page 2, the core principles of COVID-19 infection prevention, those are stressed and highlighted on numerous occasions throughout that QSO memo 2039NH by CMS. And those really do apply to all types of congregate living settings. So whether you're assisted living, basic care, or skilled nursing facilities, these core principles do truly reflect best practices and have been shown to effectively reduce the risk of COVID-19 transmission within congregate living settings. So these are basically copied and pasted directly from that memo. One of the ones that we've gotten the most question about, and I know that Bridget and Kathy have answered a lot of questions about this, and I think Bridget sent some further clarification to Shelley earlier today, but is in relation to that first bullet point on screening. And really, again, just in the example it gives of temperature checks, questions about and observations of signs or symptoms, in order to truly observe someone, that really can't be a passive process done by an automated system. And so really that does need to be an active form of screening is the consensus. The key factors to evaluate have kind of been in this document since our inception. Those that remain pertinent are also included. Some points that I just think are important to highlight are on page 3. Under conducting of testing, again, all facilities are encouraged to follow the testing frequency for both staff and residents as outlined in the associated algorithm based on your respected level of care. So again, there is some differences in the testing frequency recommendations for skilled nursing versus basic care and assisted living. However, remember that it cannot be required as a condition for visitation. Facilities may offer and test resident visitors to help facilitate visitation while trying to prevent or slow the spread of COVID-19. But we have gotten a lot of questions, and just a reminder that that cannot be required as a condition for visitation to ensue. The other part that I wanted to highlight was in regards to compassionate care, which probably shouldn't be as big of a point of contention as it's been previously, but just a reminder in regards to that. Compassionate care visits may occur at all levels of care in accordance with the definition that is provided by CMS in that QSO memo 2039NH. But again, facilities are encouraged to develop individualized policies and procedures that best reflect and outline their internal processes for these scenarios. And again, as Faye has said with prior questions that have come in, it's very hard to give a black and white answer when every facility is so different based on their staffing, based on their layout, based on their flow and various factors. And so really that using the guiding principles of that QSO memo 2039 to formulate your individualized policy and procedure is the best practice to really help navigate those compassionate care visits within your particular facility. So then scrolling down some more, the first grid that's kind of after the preamble there is going to be the updated visitation and service guidance for skilled nursing facilities. A lot of this is the same. Again, I'm just going to highlight the changes. So the first changes occurred under the column that says indoor visitation. And so for indoor visitation, whether you're in a green county, yellow county, those are the same. Facilities should consider scheduled visits with limited visitors. And that's directly from, again, the CMS memo QSO 2039. Now, if you are in outbreak status, so again, outbreak definition has not changed, having one positive healthcare worker or resident, you're going to want to refer to the bottom of this document for a newly added outbreak status flow chart. And Roseanne's going to go through that in great detail here at the end of our presentation. So I'm not going to really touch on that here. The other point I want to make is under red. So if you're a red county, greater than 10%, again, under that indoor visitation column, you're going to follow as is stated above for a green or yellow county for routine visitation, except if you have skilled nursing facility residents as a consensus or as a total in your building that has less than 70% of the SNF residents fully vaccinated, then there are some special considerations that you have to look at for any unvaccinated residents within your facility. And so really right now, when we quick did a snapshot of the state, this hopefully won't affect many skilled nursing facilities because the multitude of you have far above 70% of your residents vaccinated, but that is part of that CMS memo. And we know that admissions, discharges, deaths can all transpire, and that metric can change from time to time. So just know that if your county is in red, previously that kind of instantaneously shut down any type of indoor visitation. Now, if you're in a red county, you automatically know that your positivity rate is greater than 10%. So your next step is subsequently looking at your residents and making sure that you have at least 70% of all your skilled nursing facility residents vaccinated. If they are, great. Nothing changes. It's the same as it is above in green or yellow. If they're not, then you will have to follow some additional recommendations for any of those unvaccinated residents. The other change that occurred in the visitation and service guidance for skilled nursing, moving 2 columns to the right, is under communal dining. So under communal dining, again, in the routine pathway, so looking in routine, this again applies to the green counties, yellow counties, and red counties. We changed the verbiage in that to essentially match, again, what's in QSO Memo 2039 NH from CMS, which states limit number of people at each table with at least 6 feet occurring between residents. So really just making sure that that's transpiring and occurring. Again, if you're in routine for green, yellow, or red, making sure that you have a limited number of people at each table with at least 6 feet in between all residents. The last change is a change we've talked about before, but now it's officially on the document and you can see it. And that is, again, 2 columns farther to the right under resident screening. And that, again, dictates that you can decrease the frequency of that resident screening to 1 time per day screening via questionnaire, temperature, and oxygen saturations when you are in routine status in any of the colored counties. So whether that's green, yellow, or red. So that is now a visible change for you on this document. And those points were the big changes here on this grid for skilled nursing facilities. If you scroll down to the next document, which is the testing algorithm, really not much has changed here. The only change, again, is what we talked about previously, and that is if you are in a green county, so less than 5% positivity, we have mirrored the state guidance to match that of the CMS memo, and so staff testing should only be ensuing monthly if you are in a green county. Previously, the state guidance recommended that a little more frequently than CMS, but as we've continued to see COVID-19 cases decrease, and just for consistency, that has been changed to essentially mirror the CMS the CMS frequency that is mandated for testing in a green county of monthly for staff. The other point I just want to remind facilities at here is, as Alicia reminded everyone of the outbreak definition, just a friendly reminder that when you get out of outbreak testing or outbreak status and you are doing routine testing, that only needs to be of your staff. We have several facilities that'll call and say, oh, we're testing all the residents. And as we kind of navigate the questions or navigate the scenario with them, we find they haven't had a positive case for, 30 plus days. So just a reminder, when you go those full 14 days without any new onset of COVID-19 cases within your facility and are in routine testing only needs to ensue of your staff. Residents are not included in that until you would have a new COVID case identified, then they would have to be brought back in the mix. But again, routine or ongoing serial testing is only of your staff. So going down to the next document, which is the visitation and service guidance for basic care and assisted living. Just a few changes here to note. Again, kind of in the top heading section, just for consistency and to ease any confusion, we did retitle that first column to in-room or in-apartment visitation. In the second column to outdoor or that indoor safe designated space that we have always allowed in assisted living and basic care since early in November. So again, here for these types of congregate living settings, under routine for green, yellow, and red, it essentially mirrors what was above for skilled nursing. And again, looking at considering scheduled visits with limited visitors if you're in routine. And then once you get into outbreak, again, referring to that flow chart that Roseanne will go over in just a minute. The key here is this, again, is just for in-room or in-apartment visitation. So we know a lot of basic care and assisted livings have individual apartments, and this is the recommendation of a best practice to go ahead and institute when trying to facilitate visitation in those settings. However, moving over to the next column, as a reminder, outdoor or that indoor safe designated space, so that internal area, that one location where universal source control is followed, visitors are screened and staff monitor, that can always occur regardless of whether you're routine or outbreak, regardless of if it's a positive healthcare worker, resident, the number of positives you have, outdoor or that indoor safe designated space visitation can always and should always be allowed within ALMBC. The other part that was changed here again really is that resident screening piece. So moving 3 more columns over. Really, again, this is mirrored to reflect the change that we had talked about in weeks prior, which is having that screening occur 1 time per day when you are in routine in a green, yellow, or red county. And again, that screening that occurs once a day should include your COVID-19 questionnaires and your temperature and oxygen saturations. So those were the primary changes that were made to the assisted living and basic care kind of grid here, visitation and service guidance. If you go down, the next document is the facility testing structure for assisted living and basic care. No changes have been made to this. This remains as prior. Again, just a reminder, when you are in that routine status, you only have to be testing your staff. Resident testing is not required in routine. The last point or reminder I just want to make before I turn it over to Roseanne to kind of go through the new addition to the document, and probably one of the most important pieces, is also just a reminder about the testing. We've had a lot of questions coming in from facilities saying, has the testing requirement changed based on someone's vaccination status? So I'm hearing from my staff that at another facility, they no longer are required to test if they are vaccinated versus if they're unvaccinated. Just a reminder that CMS has not made any changes. That previous QSO memo 2038 NH remains and still should be followed for testing of all staff unless they meet the criteria for having COVID within the past 90 days and are still in that period where they no longer need to test per CDC guidance. But just because someone is vaccinated does not mean that you should be excluding them from your ongoing serial testing that is required by CMS in that QSO 2038 NH. And with that, I'm going to turn it over to Roseanne to go through the COVID-19 outbreak status flow chart for visitation.
Okay, thanks, Seth. I think you've covered everything very well. I just want to, the attachment that we put on there, and if that helps you to take a look at it and follow it with me, that might help you understand it too. But really what's in this is really just a visual to the process for outbreak testing. It's a lot easier sometimes, at least it is for me, to look at a visual and walk through it rather than try and read text and try and understand it based on a whole page of what to do. So I think what we wanted to capture in this was the question that we've been getting for the last 2 weeks, probably more than anything, is, okay, so what do I do if I have a new positive healthcare worker or resident in my facility with our testing that occurred? So if your first action step is you're going to want to complete your testing within the 3 to 7 days. And again, what that really means is not before 3 days, but not greater than 7 days. So you're going to want to do your testing for your facility, and that is going to determine your outcome of those tests is going to determine what your next step is. So if you have a new positive identified, is it the same unit, the same area? The ones that are a little bit dicey and a little bit difficult to probably understand, and this is where there's a situation where you're going to have to look at your healthcare worker and determine where have they been and who potentially have they exposed to the virus during that period of time. So that's going to be the tricky one, and that's going to be a case-by-case sort of discussion within your facility to try and determine that. I also think that I've had the question too, actually just recently, was, is this applied to everybody, or is it just, what facilities does it apply to? It applies to everybody. But I think the ones that may benefit more are those that are larger facilities that have the opportunity to cohort or make sure that, it's a unit specific outbreak, or that they can say that it's only in one area or one unit. So again, that's kind of where the facilities are going to have to determine what the potential risk and exposure might have been. And I know this is one of the things that I think everybody was hoping that CMS will clarify a little bit more, but they have not. And maybe that's okay too, because that allows you as a facility to make that determination without having it so prescriptive. And I think too, we know it's a very unique and a very individual case-by-case situation. So talking through from going back up to when you close a facility and what that visitation is suspended for your whole facility until you get your next testing done. And I just want to make sure that it is clear that compassionate care is not suspended. So if your visitation is suspended in your facility until you get that first outbreak testing, that does not mean compassionate care stops. So again, that is one thing CMS was very, very clear about. And everything that we've read, heard, that has to continue, and that is the expectation. They need to have access to their family member. And then, okay, so if you follow the flow chart through, again, same thing. Yes, no, new positive, can it be isolated? If it is in another department, another unit, it is not going to be contained. Your visitation is limited. You have to hold out and do your outbreak testing for the full 14 days before you can reopen, if it is considered in other units than where the original was. Now, going back to if it is not, if it is the same unit and you can contain it, you can open visitation in the other areas. But let's say that on your next outbreak testing, or your next round of testing, you have another one, but this one isn't on the same unit. So again, you have to shut down, you're limited, you have to complete your 14 days of outbreak testing. So I think with that being said, I mean, it's just a matter of, we took the document, put it into a flow diagram that sometimes helps walk it through. And if not, give us a call. We'll try and help you. I know that we worked with Kathy and Bridget as well when we updated the document to make sure that we were capturing exactly what CMS intended with their memo. So again, if they have anything to add, feel free to do that. And another thing I want to mention with this too is, we had discussion about changing the outbreak testing, for assisted living and basic care. And really we looked at it from the standpoint of CDC and CMS and what the recommendations are. And if you refer to Faye's document that she sent out this week, CDC does refer to, on page 3, I think it is, outbreak testing and how to go about outbreak testing and what to do in your facility for visitation. So it does reference that for assisted living and congregate care in general. So I think we have a good plan in place that will help mitigate any kind of spread or risk in the assisted living and basic care too, following the same guidance. And again, knowing that for what happens, you have to suspend visitation in assisted living and basic care for that period of time, but it is only the apartment or the in-room visitation. Assisted living and basic care have been able to do the indoor safe space from, the very beginning since we did this in November. So, that always continues. So visitation really should be open for those facilities at all times. I think, unless Kathy and Bridget have anything else to add, or Seth, do you have anything else to add that I may have forgotten?
Kathy and Bridget don't have anything to add. Thank you, Seth and Roseanne.
No, I'm good as well. You did a great job.
All right. Thank you so much, Roseanne. Thank you so much, Seth. Let's go ahead before we move on into the final issue on the agenda, which is the funding updates with Shelley. I encourage you to go ahead now and dial into the question and answer line so that we can just have you ready to go with any questions or comments you may have. 855-361-4591, star and pound. You will hear the program on the telephone while you're waiting in queue. So please go ahead and dial up now. So with that, Shelley, what do we know about funding?
Thank you, Tim. Funding, I wish I had more information, but I have a little bit of information. I just wanted to turn you to a couple of things. Number one, the retained employee tax credit, that was something provided by Congress this last year when the pandemic started. It was originally a program that it wasn't perceived that long-term care facilities would benefit much, but the rules have changed slightly. And so I just want to alert you again on the retained employee tax credit. Talk to your accounting firm to see if this is something that could benefit you. The money available could potentially be great, but it needs to be evaluated by you and your accounting firm. The second item that I've been talking about each week has been the $30 billion that is still in the CARES Act money that has not yet been spent. There is still not any guidance on how you apply for that. So just know that $30 billion is still on the table. There is not yet an application process. It is anticipated there will be. So stay tuned for hopefully, eventually, one of these Thursdays, we're going to have information. But it's still there. And hopefully, who we see would be eligible would be basic care, because they also are Medicaid providers and nursing facilities, not for assisted living at this point in time that we're aware of, but still more information to come on that. The other thing is that sequester relief for Medicare Part A. This is for nursing facilities only. As you know, you were supposed to get a 2% decrease in your rates March 31st, beginning April 1. They were trying to get that delayed again, and it was looking not promising at all. But it appears as though there might be some changes in Congress this week on that 2% reduction. So as we get information as an association, we'll send it out, because hopefully we'll know within the next week. So your Medicare payments may not be going down by 2%. That may yet get delayed. The other thing that I just want to remind you on is a 3-day hospital stay. As you know, that was waived as part of the public health emergency for nursing facilities. You know, when you're a Medicare beneficiary, if Medicare is covering your stay in the nursing home, there are very specific rules that apply. And one that was waived was you had to have 3 days in the hospital prior to your stay. That's been waived from the beginning. We've had a number of facilities really benefit from that, and or residents, because Medicare is paying for their stay without that 3-day hospital stay. That rule is still in effect. It's tied to the public health emergency. As you know, the public health emergency is in effect through at least April 21st. There's a sense at HCA that will be further extended. It's been extended in 90-day increments. We don't know yet what's going to happen, but the 3-day waiver is still into place. So I just want to remind you of that for residents that may potentially benefit, because there are some facilities I know that have been very aggressive on that, qualifying individuals. And that's been really good. The only other issue tied to Medicare is Medicare advance payment. As you know, at the beginning of the public health emergency, Medicare allowed you to get an advance payment that was always anticipated to be a loan. And now a year after the advance payment, you're having to pay it back. I know some facilities were hoping that it would turn into a grant. I think very few facilities in North Dakota applied to get that advance payment, so you now don't have to worry about the payback. But what will happen is in this next quarter, then Medicare will start zapping 25% of that money that you had in the advance. So if any of you took money in advance from Medicare to help get through the year, that is now going to have to be repaid. But I don't think many participated in North Dakota in that. I think that is it regarding payment. Again, that big issue on that $30 billion, as soon as we get information and we know there's an application process, we will inform you over and over, because we don't want you to miss out on that opportunity. So with that, Tim, I will give it back to you.
All right, Shelley. Well, we currently don't have any questions in queue. And so I'm going to go back to Vanessa and see if Vanessa has any, and she does. So go ahead, Vanessa.
Thank you, Tim. This one is for the VP3 team because Faye had to leave. It says, how should a facility handle a family member that refuses to wear a mask after continued education and wants to visit their loved one?
I guess I don't really know how to answer that. I think that's a little bit beyond our scope. I mean, we can help advise, but that might be a separate phone call. And I'm really not sure Faye would have that answer either, but maybe whoever asked that question could talk directly to us, and we'll see if we can have more discussion.
Okay, thank you. I'll forward on the email to you. Can we have pastors come lead church services for activities?
This is Seth, and I can try to answer that question. So I guess, again, it would depend on what setting. This is coming from a skilled nursing facility versus assisted living and basic care. But I guess I would just try to look at the activity you're trying to conduct, whether that's a church service or whether that's a group activity of a large game or whatever the case is, and just see if you go under the activity section of that crosswalk or grid for whatever congregate living setting your facility represents, and based off of the current COVID-19 prevalence, so the county color, if based off the guidance that's outlined there, you can safely follow that and still conduct the activity. So if this, for instance, was a basic care or assisted living facility who is in a green county, if you go under activities for routine, let's say you've had no new onset of COVID-19 cases in 14 days, so you're in routine testing, you're not in outbreak status. It says you can have group activities with social distancing, mask wearing, and hand hygiene. So there are no specific limitations there on group size or number. I think the core message is making sure, again, that those universal source control measures of social distancing, mask utilization, and hand hygiene are adhered to. So if that can be done within the constraint of the facility, it certainly would be appropriate to do so, as long as the individual who's coming in to assist with the activity is, again, going through the active screening process that is required of anyone entering the facility, and then also adhering to the universal source control that the residents should be.
Vanessa?
And could I add to it as well that nothing has changed from the standpoint of activities and all those. It was strictly related to visitation. So, the practices, the testing, all of that. So, Bridget, maybe you had something else to add to that. I think I jumped in there.
No, it's okay. I was actually going to go back to the question before that was about visitors who are not wearing masks when requested. The QSO 2039 revised, well, I think it was actually in the original as well, but the revised one is the one I have in front of me, actually does address that on page 2 at the very bottom when it talks about the core principles of infection prevention. It says visitors who are unable to adhere to the core principles of COVID infection prevention should not be permitted to visit or should be asked to leave. So I think it's pretty clear what CMS's expectations are related to visitors who are refusing to comply with infection prevention requirements.
Thank you, Bridget. I do have another question. Okay, this one is a little bit lengthy, so I'll read it. For basic care and assisted living facilities, didn't Governor Burgum rescind the executive order requiring testing or allowing us to determine our response? So in regards to Seth's comment about vaccinated versus unvaccinated staff, are basic care and assisted living facilities allowed more flexibility in how they choose to move forward with routine testing requirements, still following outbreak testing guidance?
This is Roseanne. I can start with that one. Even though the EO has gone, the guidance that we have put together for testing, for all of it, is really a best practice, and it is related to recommendations that came from CDC. So granted, facilities can make the choice to not test, to whatever it is that they do, but it's their risk. And if they deviate from the the recommendations that come from health officials, CDC or whatever, that's their own facility risk. And so again, I think that the intent for us to put together basic care and assisted living guidance for all of it, for testing, for everything, is related to best practice in congregate living. So that's what we have attempted to do.
Okay, I will go to the next question then. If a facility has different dining rooms and units, and you have a positive resident, should all dining have to be shut down? This is so difficult to shut down dining for an entire building.
Sorry, my mic was on.
This is Seth, and I can try to tackle that one. So again, I guess it just depends, Vanessa. Some of these might honestly, again, be easier if the facility calls us individually, because there'd be some dynamics. If this is a skilled nursing facility, basic care, or assisted living, there just is some difference there in the grid, as anyone who has it in front of them can see, because we did not deviate or kind of backpedal on the existing guidance for communal dining, for assisted living and basic care. And so for skilled nursing facilities, if you look again at the grid with your county prevalence, and then if you're in outbreak testing, so if you do have a positive resident, the recommendation or the advisement is not to have communal dining until you return to routine status. And so that continues to not be changed. As Bridget stated before, CMS did not really make any further changes to the current guidance for dining or activities within their revised update to that QSO 2039 NH. So really nothing has changed in regards to dining. The only change, again, that we made on this document was really in relation to the routine status for skilled nursing facilities. And that was basically to mirror and be consistent with the verbiage that CMS uses in that revised QSO 2039 to limit the number of people at each table with at least 6 feet between all residents. So essentially, if you are in outbreak status, again, if it is a resident, no communal dining should be occurring in a SNF until you return to that routine status.
Okay, the next question comes from a skilled nursing facility. Why in outbreak does the state require 3 times per day resident question screening when the CDC only requires 2 times a day?
I can take that question. So we reviewed this, Vanessa, with Faye, and Faye's advisement on that at the time was that most facilities are doing 3 separate shifts. And I believe that Faye's recommendation from the CDC stated that it should be occurring with every shift. And so after the premise that there's a day shift, a PM shift, and a night shift, that would be consistent with the methodology of doing screening 3 times a day, which Faye said at the time was the verbiage that CDC utilized for the recommended screening when you were in outbreak status, was to have screening of those residents occur every shift.
Okay, the next is in the new visitation guidelines, it now says residents need to be 6 feet apart, when before it was tables 6 feet apart with up to 2 residents at a table. Why now that why has this changed now that residents are fully vaccinated?
I can take this one. And originally when we put in, and we're talking about the skilled guidance. So originally when we did this back in October, one of the recommendations, or I should say more of an interpretation that came from HCA, was the 1 to 2 at a table. And I think that, as we have since talked about it, we have decided that we need to put it back to exactly what CMS has in their recommendation. And the reason for that is that potentially, I mean, we wouldn't want to set anybody up for a deficiency should a federal survey occur, because it is exactly, they don't necessarily give a guidance, CMS doesn't, to say that if it's a married couple, two can sit at a table, or if they're roommates, two can sit at a table. It still is the 6 feet apart. So that's why we went back to that and just left it exactly what CMS language is. And that's, I guess, the best I can do on answering that.
All right, that pause is indicating to me that we may be currently out of questions.
I'm sorry, Tim. I was trying to read through my emails to see if I missed a question here. So,
sure. We are nearing the end. So, Vanessa, if you do have another question, we would have time for one more, and then we can just add in the closing comments. But if you have one, did you find one?
I have a comment.
Okay.
A comment that was sent in. On March 11th tactical call, the VP3 team said they recognize the COVID decisions in assisted living and basic care can be made at the local level, and to document their decisions and the reasoning behind the decisions. So that was just a comment put in.
All right. Thank you. Well, with that, let's go ahead and wrap up for today. There was a lot of material covered, and I think much of it was very informative. And I just do want to remind you that we do have the information archived. I'll cover that at the very end if you need to review that at a future point. But for right now, let's check in with Shelley and see what closing comments Shelley may have.
Hi, Tim. Thanks again. Maybe just given the last comment, that Vanessa just talked about basic care and assisted living, maybe I'll just make a couple comments about that. With the rescinding of the executive order, absolutely basic care and assisted living have the ultimate authority to decide what's going to occur in their facility. Nothing really changes from that March 11th discussion or that point that was made. I think what the VP3 team and the health department and others are trying to do is provide guidance on what is the best practice. What should be the standard of practice that you as a facility should try to achieve. So at this point, what you know and what you have is a best practice standard for protecting of vulnerable individuals in your settings. If you choose to make a different decision, that really is your authority to do. The issue is, we did get liability protection passed. In there, they talked about if a facility follows, if we follow the rules, we're going to be protected. So as you decide maybe a different standard or a different practice, or you want to tweak it a little bit, I guess I would just keep that in mind as you decide what is best for your facility, what's best for your residents, what could I defend as a good practice of what we're doing. Because at the end of the day, everyone is trying to make really good decisions. So it is a best practice standard. You are encouraged to consider and adopt it. You are encouraged to develop policies on what the practice is within your facility with the consideration of those best practice standards. But clearly, things have changed. The executive order is no longer in place, and you're just as any other business, a hospital, independent living center, senior centers, those that are making decisions. They don't have people probably staying overnight, but really things have changed for you. And with that greater authority comes probably greater responsibility. But if you have questions, don't hesitate to call. If you think we need a basic care and assisted living networking session, we'd love to host another one just so you guys can talk among yourselves. You guys do a lot of learning, and it's good exchange to know what everybody is doing. With that, we appreciate all members participating. It is a helpful exchange of information, and I will give it back to Tim. All
right, thank you for that, Shelley. And let me just kind of add on to that conversation just slightly, clearly dialogue is always going to be an important part of any of these processes, and the less directive it becomes, as I think Shelley, just to camp onto that, you do have that ability, but it is within all settings, all medical settings, all healthcare settings, that risk does exist in terms of would a reasonable entity take on the same types of actions that end up causing that level of risk to be assumed and to be able to be defended. So the more that we can kind of maintain the cohesive approach, from my view, with having continued exposure to best practices or even promising practices, absent further restrictions or directives, I think the better it is for us as a whole. So that was my attempt to kind of reinforce, Shelley, what you were saying. I don't know if I was successful in that or not, but I'll let others interpret that. I know that we have come to the end, and we're going to put out some additional information about when we will next meet. We want to have basically a little bit better synchronization in terms of trying to establish an ongoing pattern. So we'll have some additional conversation with the Long-Term Care Association and put out some written guidance in terms of the ongoing schedule. So we happen to have an extra Thursday in April, which is causing a little bit of the confusion. And so we'll get something out in writing in terms of when that next meeting will occur. As I previously mentioned, we do have a website where all of this information is archived. That's at www.ndhealth.gov/ET. Thanks everybody for your participation. Take care.